Hi, I'm Lauren Henke, and welcome to another episode of the NRG Oncology podcast. Today, we bring you the first part of a special edition series of the podcast, focusing on the 2025 American Society of Radiation Oncology, or ASTRO, meeting in San Francisco. We will feature several major NRG oncology trials being presented at ASTRO, from the high-profile clinical trial session today, to the plenary session tomorrow, and to the late-breaking abstract session on Tuesday. Today, I'm thrilled to be discussing the randomized phase 2 trial, NRG-Oncology GU006, presented today at the clinical trial session. I am joined by the principal investigator of this trial, who also happens to be my boss and friend, to elaborate on its arguably practice-changing findings. So welcome to Dr. Dan Spratt, who is the Associate Chief Scientific Officer, Medical Director of the Clinical Research Center, and Chair of Radiation Oncology at University Hospitals Case Western Reserve University, as well as Chair of the NCCN Prostate Cancer Guideline Panel, and, of course, Principal Investigator of the trial topic for today, NRG-GU006 for recurrent prostate cancer.
Thank you so much, Dr. Henke. It's great to be on this podcast, and congrats on all the success of this. I'm happy to speak with you today about this important trial.
So, as a little bit of background for our audience, NRG-GU006, also known as the BALANCE trial, is a randomized phase 2 double-blinded placebo-controlled trial for recurrent prostate cancer following radical prostatectomy. As many as 40 to 80% of men with intermediate or high-risk prostate cancer actually have recurrence after surgery. And while use of early salvage, or as we call it, secondary radiation for recurrence is preferred at this point, there has remained a question of the benefit of hormone therapy to improve survival outcomes in this setting, as well as a question of how to select or identify which men might benefit from hormone therapy. Given the benefit of hormone therapy in other settings of prostate cancer management, GU006 looks at whether there's a benefit to the addition of a drug called apalutamide, which is an anti-androgen drug, to salvage radiation. Dr. Spratt, without further ado, can you fill us in on the results of GU006 just presented today at the ASTRO clinical trial session?
So, as you nicely pointed out, hormonal therapy or therapies that block androgen receptor signaling are a mainstay or the backbone of systemic therapy in prostate cancer. And it is truly a standard of care in localized or locally advanced prostate cancer when given with radiation. However, there's been numerous trials that have been run in the post-prostatectomy setting when we're giving secondary radiotherapy. And these trials have had various positive results, but really collectively, they've recently been meta-analyzed together with long-term follow-up, and there's really no signal of survival benefit, at least for men receiving what we call early secondary radiotherapy, so PSAs less than 0.5 when it's really supposed to be given. This trial was designed in 2015, so about 10 years ago, when we wanted to understand, can we use a gene expression biomarker we had developed with Dr. Felix Fang and Dr. George Zhao and myself that looks at sort of the similar biology that's been used in breast cancer for a long time, which is the luminal kind of basal signatures. So we designed this trial, and this is sort of a unique design. It's a biomarker stratified design. And we stratify patients by this luminal basal status, by the PAM50 biomarker. And it's a double-blind placebo-controlled trial, as you mentioned, giving apalutamide, which is, we call it novel hormonal therapy or a second-generation form of hormone therapy that's more effective than sort of older types of anti-androgens like bicalutamide. And this design is sort of a hierarchical way in which we test the outcomes. And so instead of like most of our trials where you just look at the overall cohort and you see does the drug benefit patients, in this unique biomarker stratified design, actually you first look at in your pre-specified biomarker positive group or the luminal B patients, do they benefit from apalutamide? And benefit here from its primary endpoint is biochemical progression-free survival, which is a composite endpoint of biochemical recurrence, local, regional, or distant failure, or death. And if that's positive, then you go on to assess it in the biomarker negative or the non-luminal B patients. If there is no benefit in the luminal B patients, then you analyze this like a normal trial. You pool everything together, you get rid of the biomarker, and you just see in the overall cohort, does apalutamide benefit these patients? And we are ecstatic and honestly surprised, given that when we designed this trial, we were using retrospective multi-center data that showed this hypothesis that luminal B patients differentially benefited from hormone therapy. And that's exactly what we saw. After a median follow-up of 5 years, the luminal B patients not only had significant improvements in biochemical progression-free survival from adding apalutamide. The hazard ratio was less than zero point 0.5 with about an 18% absolute reduction in biochemical recurrence. And furthermore, there was actually an improvement in metastasis-free survival, which is a potential surrogate endpoint for overall survival, with a hazard ratio of less than 0.3. That was statistically significant, with a large absolute reduction as well. Probably even more exciting, I mean, that's great for patients right there, but what's even more exciting is that in the non-luminal B patients, there is no benefit. So the 5-year point estimates for both biochemical progression-free survival and metastasis-free survival are essentially identical between arms, and the hazard ratios were effectively 1. And so the design was set up, and big thanks to Ted Karrison, who's the biostatistician who helped me design this trial. Our hypothesis actually panned out, which is very unusual in clinical trials to hit that home run.
That is fantastic news, and congrats on the results of the study. One question that I have, aside from the primary outcomes that you've just so nicely described, I'm curious to understand in a little bit better depth the biomarker that was used in this trial to, as you said, stratify men for randomization to apalutamide. So in addition to stratification on surgical margin status and pre-radiation PSA level, as you said, a new biomarker called PAM50 molecular subtype was used to classify these men as luminal B versus non-luminal B disease. Can you tell me more about what this actually is and what it means to have luminal B disease in prostate cancer?
So I think if you were to ask the majority of prostate cancer oncologists, they would know very little about luminal A, luminal B, and basal subtypes of prostate cancer. And that's because it has no place today as a standard of care tool. I think if you were to ask many breast cancer oncologists about luminal versus basal status, they would be very familiar with this. And PAM50 was designed initially in breast cancer. And it mirrors a lot of the subtypes that are used: ER positive, ER negative, triple negative, etc., HER2. And so we had a hypothesis, given a lot of similarities in other biology of breast and prostate cancer, right? They're both endocrine mediated diseases, hormone sensitive diseases, that we, with, as I already mentioned, Dr. George Zhao, who is a computational biologist, has many traits and skills, that he helped adapt it to prostate cancer, where there's certain genes that are not as relevant in prostate cancer, they are in breast cancer and vice versa. And so, as I mentioned, this study, when it was published in 2017, so the work started in about 2015, we were able to show a differential benefit of hormone therapy based on luminal B versus basal tumors at that time. We've now, over the last decade, learned a lot more about these biological subtypes. And so luminal A tumors, the way I think of them, is these are tumors that are technically cancer, but when we think of low risk or low grade prostate cancer, these are often luminal A tumors. They don't have to be Gleason 6. You actually see luminal A disease, even in this trial, about 10 to 20% of patients were luminal A. These patients rarely, if ever, develop metastatic disease. So they're a very indolent type of cancer that a lot of people want to further investigate. Should we just be doing conservative management and, I don't want to say ignore the grade, but potentially irrespective of the grade of the cancer? Luminal B tumors tend to be high AR activity, meaning their androgen receptor activity is very active. And we've shown that these are tumors that are much more likely to be responsive to hormone therapy. And they also have higher proliferation. So, unlike luminal A, which may also have some high AR activity, the proliferation is usually lower. So, these luminal B tumors are tumors that, if treated effectively despite a high proliferation rate, can likely be cured. And basal tumors are kind of a hodgepodge, but they tend to not be as androgen receptor active. Some of these fall into the low AR activity group, which is sort of a poor prognostic group, but some of them also just aren't as proliferative. So it's not uniformly a poor prognostic group. But because they're not as AR active, the hypothesis is that they don't seem to really benefit from hormonal therapy. This test is owned by Veracyte. They also own what's called the Decipher test, which is a standard of care gene expression test. And so what actually is done is you run the Decipher 22 gene assay, and part of it, they assess the entire transcriptome, including the genes that make up this PAM50 test. So on this clinical trial, all patients underwent transcriptomic testing, and they received both the PAM50, which, as you mentioned, patients were stratified prospectively by. We also collected the Decipher test, which is a prognostic test that predicts the risk of metastatic disease for this population.
That's a really helpful overview. One quick question, just to sort of expand on that, is this a test that can be routinely ordered in clinic now? You said that it's run by the same company that does Decipher, so presumably yes, but is this something that can just be part of a routine order set already?
Yes, it can. So right now, when you order a Decipher test, there is something you can obtain as well if you want. It's called the grid report. So because most of the whole transcriptome is analyzed, numerous other signatures you can have available and reported, but it's part of a research report. So it's different in that the Decipher test or tests like it, a clinical pathologist signs off on the result versus the research report, they don't. But my understanding, again, I'm not affiliated with the company kind of in any way. My understanding is likely based on these results, this will become a companion clinical test given it's now validated in a prospective randomized trial. This gives what we call, for those familiar with the biomarker level of evidence, so it's called Simon criteria. This gives the first time ever what's called Simon level 1A criteria, which is you run a prospective randomized biomarker directed or biomarker driven trial, where previously, all the best evidence we've ever really had is post hoc or retrospective analyses of completed prospective trials.
That's pretty incredible that this is the first prospective data for using this type of test. Another question I have is what specifically led to the choice to test the drug apalutamide in this trial? You mentioned that it's a newer type of drug and potentially more effective, but those in our audience familiar with prostate cancer treatment may know that multiple versions of androgen deprivation therapy and/or anti-androgen therapy exist today. Why was apalutamide used in this trial? And how was the 6-month duration of anti-androgen therapy chosen?
That's an excellent question. The most common form of hormone therapy given in prostate cancer is an LHRH agonist, things like leuprolide, typically given in an injection every 3 to 6 months. That effectively tells the brain to tell the testicles eventually to lower testosterone. So that's one way to kind of inhibit androgen signaling, is to just lower testosterone or the ligand. The other is to block the androgen receptor. And so historically, drugs like flutamide and bicalutamide, and there's others, are not actually that potent or that effective at blocking the androgen receptor. And they've got their own milieu of side effects. Starting just ballpark around 2010 is the beginning of when a variety of second generation, we call them androgen receptor pathway inhibitors, and they include apalutamide, enzalutamide, now darolutamide, have incrementally over this past decade gained FDA approval in patients with advanced, usually metastatic, if not castrate resistant prostate cancer. And they're much more effective at blocking DHT or testosterone from binding to the androgen receptor. And given how effective they are, increasingly we are seeing studies of using them as monotherapy, meaning in almost every other disease space, you always give it with something like leuprolide, where you lower testosterone and then you give the anti-androgen to kind of block the last little bit of testosterone that may exist. But in this setting, one of the benefits, if you can just block testosterone without lowering it, that means you still have circulating testosterone around. And so there is some evidence, even with these stronger anti-androgens, that quality of life in patients is better when you are on an anti-androgen, one of these next generation ones, than if you were on traditional androgen deprivation therapy. So one of the motives was, can we not castrate patients or lower their testosterone while maintaining efficacy? Number two, could we potentially have even better efficacy given these are potentially much more effective than just ADT? And then three, at the time, really, there was only two of these next generation anti-androgens out. One was enzalutamide, the other was apalutamide. And we were running a different trial called STEEL with 2 years of apalutamide and sort of more advanced recurrent prostate cancer. And so, kind of to diversify the portfolio, as well as there's potential benefits preclinically. The laboratory I actually worked in training with Charles Sawyers, he developed both enzalutamide and apalutamide. And apalutamide is technically a more potent form of a hormone therapy than enzalutamide, at least preclinically. Clinically, each company will debate what's better. But that was sort of the genesis of this. And the 6 month duration is really, in general, that seems in most of prostate cancer, the bang for your buck comes during that first 6 months. Whether longer would be better, it's possible, but also, of course, side effects would increase.
So, following NRG-GU006, what is next to come in the GU space? How do you build forward? Or maybe I should say, how is the GU team already building forward on the back of these results? You mentioned that it might be exciting that patients with non-luminal B disease have no clear benefit of anti-androgen therapy, but is it also in some ways a bit disappointing to see a lack of clear benefit for them? Are there clear paths forward to help those men have improved outcomes as well?
Yeah, I think the name of the game always is keep moving forward. In that, I think one of the things we've really focused on is a lot of times, right, people do research for the sake of research. And I think one of my goals has always been, how do you translate any research to change national guidelines, change payer coverage, and then so you can ultimately use this routinely to change the way patients experience life. Obviously, any trial result will have different interpretations. Some people will view this, I think, very clearly as this is practice changing. This will be used always in their patients in this specific context, not necessarily in other contexts, to help guide the use of hormone therapy. I think there's probably people that even other biomarkers or tests or treatments that are viewed as standard of care, we know that not everyone follows standard of care and they may not view this as practice changing. So it'll be interesting how the community reacts. I think that one of the strengths but challenges we knew when we designed this is it was sort of designed as a phase 2, 3 trial, thinking that, a sample size of about 300 to see, can we get a signal on biochemical progression-free survival, which I've written extensively on, is, has some value, but in and of itself, that endpoint alone is not powerful enough, in my opinion, to change practice. However, metastasis-free survival is usually the primary endpoint we use in most of our phase 3 trials. And as I already mentioned, the hazard ratio is 0.27 in luminal B patients, and it was 1 in non-luminal B patients. And so it's already, because it's such a powerful biomarker and the treatment is effective in these patients, we have done sort of an informal NRG poll, actually, of the GU core committee. And of nearly 50 people present, we asked them the hypothetical result of basically what the real result was, of if it showed these results, would you feel you're willing or ethically willing to randomize luminal B patients to not receive hormone therapy? And one of the 50 people raised their hand, and then the people said, do you feel it's ethical, or are you willing to randomize non-luminal B patients to hormone therapy? And again, only one person raised their hand. And so amongst experts across, usually representation from Canada and the United States primarily, there's not even much equipoise to conduct another trial, given we've also have all these, again, how you interpret them is in the eye of the beholder, but I would argue most trials have not shown major benefits in biomarker unselected patients who are receiving early salvage or early secondary radiotherapy. So I think unless another country ends up running a similar trial, this will probably be the trial that answers this question in early salvage radiation therapy. Now, the question is to build on this. We're already in plans in the GU team in localized prostate cancer. Hormone therapy is the number one driver of decreasing quality of life. It's not radiation, it's not even surgery, it's typically hormone therapy. And so there's great interest to how do we personalize the use of this. And so one of these settings is in what's called intermediate risk, or specifically unfavorable intermediate risk disease, where we're near complete in a trial right now using the Decipher test on NRG-GU10. Can we use a prognostic test to identify patients who may not benefit? But would be even better is, can we have a predictive test that just biologically, irrespective of prognosis, identify those who do or don't benefit? And so that trial is well underway in terms of design. It'll be led by Doctors Angela Gia, is your counterpart here at UH-Seidman in Case Western, as well as Dr. Bob Dess, who is one of my former mentees, and he runs with Dr. Will Jackson the GU program at University of Michigan. So they are co-leading the development of this next big phase 3 trial that will be using this PAM50 biomarker. So I think we are planning based on other trials that have been done in this setting. We'll be doing an individual patient meta-analysis, analyzing other major trials that have been plus minus hormone therapy to see if this signal is consistent across all the trials. So I think that's really the work that's planned or ongoing. Now, to your question on what do we do with these basal or non-luminal B patients, it truly is an excellent question. And I think that right now it's unclear, is there a great systemic therapy that will specifically target that biology? Some would have thought it's chemotherapy, but actually we and others have shown that actually, if anything, it seems that the luminal B patients also benefit more from chemotherapy, and maybe that's again due to the more rapid proliferation. Some have hypothesized maybe PARP inhibition. We ran a trial with that hypothesis in Nature. We don't know yet if that's going to pan out, but we will, of course, keep looking at different targets to be able to best improve outcomes for all patients.
Switching gears just a little bit, one element that you also highlighted in your presentation today is the frankly incredible pace of accrual that this trial had. The study team accrued at a pace 3 times faster than predicted, which almost never happens in major randomized trials. I also can't help but notice that there are 4 major GU trials being presented at ASTRO this year for NRG across the plenary, clinical trials, and late-breaking abstract sessions. No other disease team is so well represented in major sessions this year with this many major studies. And it comes right down to the impressive pace being kept in prostate cancer and GU research in terms of trial generation and accrual. So I think many other research teams would love to replicate this success. What is the secret to the success of NRG-Oncology's GU disease team over the years?
Well, I think the success to any team comes down to the team itself and to the leadership. If you look at the trials being presented, the leaders of the group were Dr. Howard Sandler for decades, and he passed the torch to Dr. Felix Feng, who really transformed the GU group. I was very fortunate that he brought me under his wing as one of the subcommittee chairs, as well as multiple other leaders. And I think the team, it's very large. I don't attend all the different NRG core committees. But the GU one is huge. I mean, it was maybe 10 people when I started as a resident. He brought me in. It's now easily 50 plus people in these core meetings, not the general meetings, the core meetings. And so really trying to engage the entire team from people across Canada and the United States and even other countries as well have participated in some of these trials and really trying to share the wealth. I think when I look back to early in my career, there was a small number of GU very senior people that pretty much populated the majority of the trials. I think, Felix and I had many conversations that we never wanted that to be our legacy. We wanted to give as much opportunity to junior faculty and to really spread it out as much as possible. He passed that torch to me, and I was very junior. I was just a few years out of residency when I got the opportunity to design this trial with him. And we've continued to try to bring in as many junior mid-career faculty to help with this and to really limit mid to senior faculty from being PI again unless there's some real reason for it. Because at the end of the day, the goal I think in the GU team is it's not about the investigators, right? It's about changing the field and changing practice. And as we all get busier and busier careers, I can say for myself, you will have far more energy to go the extra mile earlier mid-career to do one of these trials and to make videos, to get the IRB approval, to really get buy-in from medical oncology, surgical oncology, etc. So I think that's been a big part of the success. I think the other part that I sort of view as sort of my job in part on the committee is trying to have a finger of the pulse of just, we'll say, the community radiation oncologist, not just the ultra academician, because sometimes people nerd out over these really subtle things that's not what the average oncologist is thinking about or they care about. And so you got to think of trial concepts that people care about, they really want to enroll on, and accept that some of these other more nuanced questions may be very important, but that may not be great for a whole national or multinational trial. And I've learned a lot from, it's called the Stampede trial. Some may be familiar. It's run out of the United Kingdom. And it's one of the most practical trials. They've enrolled over 15,000 patients and they've changed the standard of care numerous times over. And they enroll mainly metastatic patients, which is a much less common form of prostate cancer. But they're out accruing most localized trial groups in the world. And it's because they keep it so practical, where, sometimes we try to be so prescriptive on exactly everything when many of the things in our trials, so for example, what we've done for our trials with, let's say, adding a drug, changes to radiation therapy have not really shown to change survival, right? Whether it's your margins or your dose or adding brachytherapy or SBRT, they may affect toxicity, but if your primary endpoint is metastasis-free survival, then we should make sure the groups are balanced, but we should be as practical as we can be because we don't want to limit people who, let's say, do a lot of SBRT or who use, longer fractionation courses. And so we're very permissive in as many variables as we can be. So I think all of those things combined of picking questions that matter to the bulk of the people who enroll and not getting tricked that these ultra nuanced questions that only experts care about, as you know, they're not the ones who are going to enroll 2,000 patients on a trial. They may, if you're lucky, enroll 40, but you really need the buy-in of the broader community.
I think that's a really important perspective to have, not only that your study goals need to represent the needs of the field broadly when we're conducting these big trials, but also on the efforts being made in the GU team to kind of steward young leadership to be looking forward with. Speaking about strong leadership and mentorship within the GU team, I have to say I know firsthand about your skill in leadership getting to work with you each day. But I know that this trial holds special meaning for you as you presented it, as you said, also on behalf of your friend and co-PI, Dr. Felix Feng, who passed away last winter, not long after the 2024 ASTRO meeting. You've mentioned it already, and I absolutely agree that Felix was someone that many people have identified as a mentor, a leader, and a friend in the field of oncology. On a personal level, what was it like today to present in his honor? And maybe what traits or habits made Felix such an example of leadership? Are there any lessons in leadership that you carry forward from him?
Yeah, it really is something that very few things in my life sort of bring tears into my eyes. But thinking about Felix, the reason it does, it wasn't just a standard, he's a mentor sponsor, which he was to me. We went at it. I mean, he and I, if you go look, I was very honored to speak at the first ever, it's called the FANG Symposium that was created in his honor. And I got to speak at that. And I'll be giving actually a talk at the Prostate Cancer Foundation at the end of October in honor of Felix that now is there each year. But if you go look, and this isn't at all to any way to boast about myself, is that when you look, Felix was prolific, but I'm the number one person who has published with Felix by more than I think the next two, three people combined. I mean, he and I worked together extensively. He helped recruit me to the University of Michigan. We talked about his personal, his family's thoughts of moving to UCSF and to California and the noble reasons in which he did. Both of our different career aspiration challenges in being dads while working. He was one of the few people that actually I feel understood my ambition, that understood what some people would think is a psychosis, that he understood it, but also kept a kind of a mirror to me that I could see sometimes when he was doing things I was doing or vice versa. And yeah, he provided this just amazing lens into the type of man, the type of father, the type of researcher, the type of leader I want to be, and what certain behaviors I do or don't do, and the potential impact on others. And so I think he provided like an accelerant, like a catalyst to help me advance in that leadership. And I would like to think, as we got further, as I moved here to become chair, I don't want to say the roles flipped, but we became less mentor mentee and really became really just providing genuine, humble advice and question to one another without sort of hierarchy. And so Felix, as you mentioned, he was at ASTRO last year, came to our department party, was there, was amazing to see him and his wife Mary. And obviously, he was already, you could tell the signs of cancer was just having a toll on his energy. The day before Felix had passed, I basically shared everything I would want to share with him. And, I felt that he accomplished more than dozens of people do in a lifetime, but I feel like we left at such a good point between each other. There's just true love and respect. And the part that I just wish, but I will carry on the legacy the best I can, is a week after Felix passed, I got these results. So the very first results met its primary endpoint, was sent to me before any of the cleanup that happens with biostats. And I was, again, just floored. I was super surprised. I mean, I didn't think this trial was going to be a home run. I thought, yeah, maybe there's some signal, maybe it's positive, but I didn't think it was going to be just true home run because so few trials are. And to see that, I just wish I could have shared that with Felix, 1 week earlier, that, this thing that we just talked about and designed back my basement of Ann Arbor and my teeny little faculty office that was basically a closet, that what this now 10 years later I think is going to change the lives of tens of thousands if not hundreds of thousands of men. It's pretty remarkable. But I think that's what Felix is known for, is he was a mentor. He brought people together. He's someone that will bring people with talents together to be able to solve problems he on his own couldn't. And he did that over and over and over again. And this is just one example of that. So I'm honored to get to be co-PI with Felix on this, and just one more example that even after Felix has passed, still making an impact on this world.
That's pretty incredible and very just kind of surreal timing of the results that you received. Congratulations on this trial and on your presentation at the ASTRO clinical trial session today. Thank you for joining us today on the Energy Oncology podcast. And thanks also for your years of effort and leadership and service to energy oncology in the realm of GU oncology.
Well, thank you so much for having me on this, and thank you for taking the time to do all of these. I think this gives a lens that I wish, if I were to rewind the clock 10 years, I wish I had the lens into what all these different experts in their different domains, how they think, who they are. Often you never get to even hear them speak, and the way they view their own trials or their careers or their results. So appreciate you doing this for so many out there who listen.
Well, thank you. And for those of you who haven't already, you can, of course, follow or subscribe to the Energy Oncology podcast on Apple, Spotify, or YouTube. And we hope that you will keep up with our team as we continue to highlight major NRG trial results from this 2025 ASTRO meeting. The NRG Oncology Group is supported by grant funding from the National Cancer Institute, and content of this podcast does not necessarily reflect the official views of the National Institutes of Health. Thanks everyone for tuning in, and happy clinical trials.